How do you triage a patient in the emergency room? Hey, welcome back everyone. Emergency Room Josh here. So in today's video, I'm going to talk to you about triage. Triage is a fundamental part of emergency room medicine. Every single patient that comes to the ER has to be triaged, and it's critical that this is done accurately because the outcome of these patients can largely be due to how accurately the triage was performed. So the term triage means the preliminary assessment of a patient or casualty to determine the urgency or acuity of the patient's illness or injury. Basically, triage is assessing a patient's acuity, which will determine the order of which patients get to go back and see a physician first. So triage is performed by the triage nurse. The triage nurse is the gatekeeper between the waiting room and the ER. This is usually preferred to be someone who has some experience under their belt. If you've been in the ER a while, you're going to be a little better at recognizing certain symptoms and presentations, and you may be able to assess and triage people more quickly and accurately. In fact, many times ERs have protocols in place that won't allow you to be the triage nurse until you've worked there at least a year. So when I first got out of school and started in the ER, I was kind of terrified about the thought of being the triage nurse for the department. It's really scary to have that much pressure on you to be the one who's deciding who needs to get back to see a doctor first. So I'm making this video to try to give you guys some tips and maybe help you be prepared and not feel so threatened by this concept, because there are some tools to help you triage effectively. Experienced triaging is very valuable, but it's not the most important thing. Most ERs follow particular algorithms and outlines that help you triage people. And the one that you're going to see a lot is the Emergency Severity Index, ESI. This is the standard in a lot of ERs, and that's the one that I'm going to be kind of referring to today. Now, disclaimer, this is not actual medical advice. I'm just giving you my opinions on how to interpret the ESI and some tips on how that works. The ESI has 5 levels to it, and they're based on the acuity and the resources required to stabilize or treat that patient. Level 1 is the highest level of acuity. That means the patient is either dead or dying, and that they require immediate life saving measures. Level 5 means that the patient is completely stable and will require no resources. An example of that may be someone who just came in to have some stitches removed, or they want their seizure medication refilled. So we're going to go over the 5 levels, what that looks like, and then also kind of the definitions of what is considered a resource or not. You would call the next patient back to the triage area, and you would get their vital signs, or they may have already had their vital signs taken by the registration staff. Just depends on how it works in your ER. But after vitals, you would ask them what brought them in, and usually there is a charting kind of outline that you would follow and ask the same questions to all the patients that you see. That kind of helps guide you to get your answers more quickly and to find out what allergies they may have, a little bit of their history, and you want to get this process done as quickly as possible, probably for sure less than 5 minutes. 3 minutes may be the goal, and you're not there to do the full assessment as the nurse that's in the actual ER would be doing, but your goal is to quickly move through the ESI index and determine their acuity based off of their vital signs, their presentation, and basically the quick interview you have with them about why they're there. Here is the ESI algorithm. As you can see, level 1 would be patients that are requiring immediate life-saving interventions. This would be a patient who is having an active cardiac arrest or an active respiratory arrest. If you're losing your respiratory drive because you maybe overdosed on drugs, you're completely unresponsive, or your GCS has declined to like an 8 or 9. Also, if you're having like an allergic reaction and your airway is closing up and you're not able to inhale adequate volume, so they need to be taken straight back and treatments need to begin immediately. Then you have your level 2. These are patients that are high risk and do not have stable vital signs. They're maybe severely sick or in extreme pain, and they're gonna need many resources. This is a time-sensitive patient. They need to be seen as quickly as possible, hopefully immediately, and these are patients that may have acute signs and symptoms of a stroke. They're having circulatory compromise, like maybe their heart rate is less than 50 or over 150. They're having respiratory distress. They're going to have maybe a really high fever or chest pain. If they're hemodynamically not stable, their blood pressure is like 70 over 30. Obviously, they're not perfusing correctly. There's a lot of things that can fall into this category, but you're going to look at their are they lethargic? Are they confused? I think what's really going to help you distinguish between a level 2 and 3 the most is the vital signs. This chart goes into detail about what the normal ranges would be for your age group, and that kind of helps you determine if this needs to be a level 2 or a level 3 acuity. What is considered a resource in the ER? This would be your labs, so blood work, urine. It would be tests like an EKG, imaging, so X-ray, MRI, CT. Those are definitely resources. If you give IV fluids or IV medication, that is considered a resource. Specialty consultations, simple procedures, like a laceration repair, or a complex procedure like a conscious sedation, those are going to be resources. And within each class, like labs, for example, if you have to get blood work done and you get a CBC and a BMP, even though those are 2 different labs, that's considered one resource because it's that category of labs. Things that are not considered a resource in the ER is your giving your history, getting your assessment done, even including like a pelvic exam. That's not considered a resource. If you are given oral medications, like you come in and you have a fever and they give you some Tylenol orally, that's not a resource. Simple dressing changes, maybe like getting crutches or a sling for your arm, those are not considered resources. So whenever we're talking about how many resources it's going to take, you're going to kind of have a chart that would help you whenever you're new to looking through your triage notes, and that will help kind of guide you on how many resources do you think that kind of patient is going to require. This is another reason it's helpful to have your triage nurse have some experience, because if you're used to being in the rooms treating these patients, you kind of get an idea of what resources would be needed for certain types of patients. Like if they come in and they've been having painful urination and frequent urination, you're suspecting like this is probably a UTI, we're going to do urine for sure. So that's one resource. You may stop there unless there's also been like, abdominal pain and vomiting. That probably would tell you we're probably going to do some blood work, start an IV. We may give IV fluids, so that's another 2 resources. So in your mind, you're already like, this patient is at least going to be a level 3 just based on the resources that we're going to use. Your level 4 patients are going to be the ones that require just 1 resource. So an example of that would be, like I mentioned, an uncomplicated UTI. You're just going to do a urine sample for them. You may have someone come in with a sprained wrist. You give them some ibuprofen. That's an oral medication, so that doesn't count. But then you may follow up with an x-ray to make sure there's no fracture, but that is considered a resource. So that's just 1 resource. That's your level 4 patient. Same thing, like if they had a small laceration and you give some oral pain meds and some sutures or something like that, that's just 1 resource. So lower acuity, they are stable, their vitals are stable, and they're just going to require 1 resource. And then you have your level 5 patients. Again, these are your patients that are going to require no resources. They are stable. They could probably be treated in a clinical setting for their complaint. An example of this would be a kid who comes in with poison ivy, and so they're going to be prescribed to go home with an ointment or medication to treat that. That's no resources. Or someone who ran out of their blood pressure medication. That is also no resources. Maybe they need to get their sutures removed that were put in a week ago. So those are you're going to be your level 5 patients. So I hope this video helped kind of clarify and clear some things up for you. The ESI algorithm is very helpful because, trust me, it can be really stressful triaging someone. Like, for example, if they come in with chest pain and you're like, oh, like they have chest pain. What if they're having a heart attack? I don't want to miss that. Like, do I need to send them straight back right now? And you're looking at their symptoms. You're like, all right, is this a 18-year-old with no other symptoms? Or is this a 60-year-old who is also diaphoretic and having jaw pain and numbness shooting down his left arm? The algorithm lets you look at their vital signs and kind of helps guide you to what acuity level that patient should be. In my next video, I will go through the next step of the ER process, which is your initial assessment. I'll go in depth on what that looks like, some tips and tricks on how to approach that, and we will move on after that and look at your discharge instructions or admission criteria. So thank you guys for watching. I hope that you got something out of this. Please like this video and subscribe. That means a lot to me, and I will see you guys next time.